Good evening, everyone, and thanks for joining in another Acchutha's INSPIRE series. Today we have Dr. Krishna Kumar, who needs no introduction. He was my former principal at Elite School. Currently, he is a freelance optometrist, and he also been a key person in optometry services, Shankara as an advisor. He has also started a unique thing like a Doorstep free Geriatric Eyecare in Chennai, and which is very unique. And congratulations on that, sir. So today, sir is going to talk about what is the role of optometrist, be it a healthcare professional in serving psychologically affected individuals. Yeah, sir. Over to you. Thank you again for accepting our invitation. The screen time is yours, sir.
Okay, thank you, Gopi. At the outset, I would like to thank the Inspire team for doing a wonderful uh, job of sharing knowledge and connecting with people, and which in turn definitely would have had impact on our patient care. And with that perspective, when I was invited by Acchutha Inspire team, um, I was telling that I would like to take some time before thinking of any topic or anything specific that you would like to suggest. And at the end, I turned up with this topic, and immediately thank you, especially Saranya Madam and Inspire team, Gopi, Saravanan, and so on, for agreeing on this topic. A lot of people wonder actually, this is a topic where it looks like I know, but at the same time, we also feel I don't know. But one thing is very, very clear. This is something which all of us should realize that unfortunately we don't implement this, though we as much we think and feel that I know. And basically, I always feel the health psychology need not be a separate one. It should be an inclusive of our any healthcare profession. So too with optometry. Only in these two lines I can just give a gist of this area of interest. One is we all realize that people who have, when we are psychologically impacted or affected, maybe it's a short term or it is a long term, you know that what kind of impact it creates on our relationship and on performance. At the same time, we also should realize people with some kind of ailment. Think about a situation where you had fever and how you act differently. There is a demonstrable proof that our mental status impact our health, and our health status will impact our emotional status. This vice versa aspect is what something need to be probed into, understood into, and not only with that, but we also have to implement into our practice for the betterment of the patient care. Whether it is happening or not, maybe it is happening, but it is not happening with the proper constructive way or structured way as we do expect in any other implementation. I think that is one cause. The reason why I got triggered with this area specific of late is there was a request for from one of the rather two of the centers who holds people with psychiatric issues. I'll try to say one gamut of group is of intellectual disability. Predominantly, it is of congenital nature. Another center is predominantly with acute, probably with inherited etiology as well. Now, these two groups, when there was a request came, I I was just looking at before agreeing on whether anything that I could contribute more than just eye examination, or our eye examination per se I can add value, have understanding their needs and their challenges associated with their condition. That's how it all started, and there was no doubt there was a great learning, mutual learning between me as well as the inmates of them, and they tried to was it was an eye opener per se. Though I thought initially I will try to dwell upon sharing those kind of experience to them, but I realized the content in this area is so vast, so I want to touch upon some of the fine aspect which I thought prioritized, and that might add a lot of value to our practice, provided you just think about whenever you handle a patient. And it is purely an experimental basis. I'm just trying to put down according to my priority. And towards the end, uh, if the organizers feel that I have adequate time to share, I will just share some of the data about eye related issues in people with some of the psychiatric problems. Another trigger, third trigger, which came up is, which also I have to vouch for it. As much we say there is vulnerable group who required equity and equal kind of care, and that's why we try to talk about inclusiveness in our eye care. I was wondering, is there any adequate data for us to say that how many of such patients I handled, especially with a definite diagnosed patient with psychiatric problem, mostly psychotic in nature, whether we have handled so much. And I realized that, first of all, the eye examination for these people is still in wanting. And in sense that as much I feel, though unfortunately none of the guidelines talk about this group as a vulnerable group, as much we talk about aged people, people in the women, people in rural areas, and migrant people. Now, all these people we tend to talk as an important group of people. Vulnerable group requires equity care or inclusive eye care. I don't see this group is nothing, but I realize that this group we don't have adequate information, except in last I could realize in 2016 there was a paper came out with that too with around 30-40 members to see what is their eye care condition, but generally it is not there. Other anecdotal information we do have, if we do have seen any of those patients and whether they represented differently, I could recollect only two. The one is which I personally had an opportunity when we were dealing with a patient of 29-year-old with accommodative spasm, when where they were put with ophthalmologist guidance, no atropine. But when even after we've realized clinically there is a stabilization of the refractive error, I don't see why the person has to give this fluctuation in vision on and off. And only to realize, cutting short the whole story, only to realize later on that the parent, especially father, came in one of the no informative meeting, came out with this diagnosis which we never asked, never they revealed that the patient had schizophrenia. And whenever he stopped the medication, this hallucination, not even delusion but hallucination, as in gave an impression that is a fluctuation as defined by the patient. This is something that is one incident, and later on, no, the patient got benefited by referring to the association where they deal with this exclusively. The second case, I remember it is, I didn't see this case, but I happened to listen to the talk and I also saw a few publication related to it, is on angle closure attack when patients who use a topiramate, especially people with schizophrenia, bipolar, they tend to give this thing for other reasons. And we found that these are the two anecdotal incident I could recollect. And there are few, when we looked into the literature, there are a good number of cases where we could see there is some association. So all it says that there is a huge gap. Probably each one of us can try to probe and see whether there is an add-on value to the patient. But what is the present burden of this mental disorders? Maybe since we are seeing it rarely, I also looked into this global burden of disease study specific to India. And we realized that almost 14.3%, there's no big difference, gender difference between male and female, that we do see the prevalence in the higher range. And it is more than refractive error, believe it. And in that sense, it's compared to the school children thing, it is more. And predominantly, if you can classify idiopathic developmental thing, which is higher compared to other things, actually. In fact, that's what it's aggregated, two homes for this and the other one, so that it is clear cut that there is a huge number of people. If you convert into the absolute number, it's almost 197 0.3 or 19.7 crores or so people with all different mental disorders. Now, what is the status around the state? Interestingly, look down south. I'm not getting critically looking into the finer reasons why, and so there are few debates always, but still you can see there is the huge number of people with anxiety and depressive disorders in the down south, especially involving Tamil Nadu, Andhra Pradesh, Telangana, so on, and somewhere it's creeping into Kerala as well. Both depressive and anxiety disorder, but also look more thing more reddish in color in Tamil Nadu is for depression than the anxiety disorder. This is something which we have to give a lot of importance to. And one thing, if you look at closely as with age, what is happening, because we are dealing with a wide range of people with different age group. You can look the depressive, like especially depressive disorder is actually increasing in nature, especially people with vision impairment, vision loss, low vision. This is something which we have to keep in mind. Um, the depressive disorders with age, it is increasing, and therefore whether we do have any play there in addition to what we provide as a service to those people, especially when they come with vision impairment. Anxiety disorder is looks like in the mid-range crisis, it is increasing, and it is also dropping down, but it is not dropping down to the plateau, but still compared to any other disorders at the height. So depressive and anxiety disorder are something which we have to focus more as an eye care professional, because there are lot of work has happened into the impact of our vision related and ocular morbidity issues and depressive and anxiety disorder with adequate evidence for us whether we can try to put these things into practice. And of course, the other aspect is bipolar disorder and schizophrenia is also concerned. At least when I looked into mid-range, especially the age group which I dealt with between 20, 31 years up to maybe around 40, 50 to 60 years, predominantly schizophrenia, but bipolar haven't seen individually more. But if you look at the trend per se, in this case, the trend looks very interesting. This mid-range area, which is something which think maybe we can keep even up to 60, 69, we'll see some of them. The higher range is between 30, even the range which I've seen, the peaking range is around 30 to 40 years. But even this cutting across the state also show. So the focus of interest, at least for me, it looks like depressive disorders, anxiety disorder, schizophrenia and bipolar, I will keep as the topmost. And many of the works in relation to this, to the vision, eye, is there adequately in this thing. Of course, intellectual disability, right from young age, many of us would have worked. With age, it will dwindle for because of their longevity, lifespan issues per se. But something which I strongly feel as an optometrist, this four area is untouched adequately in our practice. Of course, the artistic spectrum disorders, and I see there are some of the optometrists trying to focus in that area, see how as an optometrist I could contribute towards that one. I've seen some of them, I'm not going to talk much on it. And attention deficit hyperactivity disorder also, there is some kind of growing interest among the eye care professional, but the intervention part still I feel there is a long way to go to think through. At least the referral part, I do agree on it. To a large extent, we can do it. So I could really see the first four aspect of it somewhere in the adult population. Autistic and attention deficit is towards the pediatric population. and whether we do have any role, maybe we can include intellectual disability. This three can be fit into the pediatric population or pediatric optometrist or eye care professional. The rest of the four can be thought from the point of view of people who are dealing with adult or geriatric population. Okay, so what I'm going to do is these are the six area. Plus, if I want time, I will try to share my experience. These are the six areas that triggered me. So I thought I will also share those triggered to you and see whether we as an individual eye care professional not only think from the perspective of the patient alone and the relatives alone, but have you ever thought the patient care from the point of view of your emotional status? The first three points which I want to highlight, the importance of personal development. Without that emotional stability, without that aspect of it, there is no best patient care. So I thought the first three, probably a trigger mechanism. I thought we have to look into ourselves before trying to talk from the point of view of the patient's emotional status. The next three is I'm going to talk, is there any relationship between the psychiatric condition and ophthalmic disorders? Is there any evidence we do have? And ocular manifestation, psychiatric condition, so that we can play a role of picking up early and then referring. And of course, the impact of psychotropic medication on eye and vision. Now, this is an optometrist X, imaginary, it is an imaginary thing. Probably it might have a shade of someone whom you might be thinking, but it is not anyone of that kind. It is a purely imaginary. Optometrist X, it has been considered to be an expert in a tertiary core hospital, is well read, well, no, academic, good, very good academic performer. He or she was a great clinical researcher and has good many publication. Definitely, every one of us wants to be like that, no doubt about it. But interesting component of it is he was being feared by all. No one would like to go closer to him or her. And this aspect of it, both the dimension of the perception of others about the person and was well aware of aware by that individual. The awareness of that perception is very clear to that individual. But unfortunately, despite being the brilliant of brilliant in his clinical career and research, he could not help himself out of it. So therefore, there are a lot of noise in relation to who he is or who she is. The person is hysteric. You can't predict. We can't predict the person. You can't cross before go to better cross check with his secretary before going close and interact with him. Maybe he had fight with wife or husband, carrying his personal problem and venting out on us, sometimes very good, sometimes kind, and which no doubt he or she is very straightforward. Only when you are wrong, he shouts at you. Always there is some genuine reason, but he never see who is around when shouting at you. Look at the no complication of no credits he get from different kind of people, but he is well aware there is something a person has to do. Don't you think, friends, that our emotional status as an optometrist might have had some impact on our patient care or not? Yes, these are the three key take home message for each one of us. Are we sensitized with the feelings of others in all our conversation? You might be brilliant, you might be good, but are we sensitized to the feelings of others in all our conversation? I'm trying to restrict ourselves to the clinical thing. If you take message to outside, well and good. Is it not important to learn the art of segregating personal issues from from professional work? Do you see the potential impact of our emotional state on our patient care? If you get no answer to it, probably I feel that is the first implementation that we need to do in our clinic about ourselves, because it is going to have an impact on my care towards my patient. The second message or second trigger for me is there any aspect called no making mistake? If a person makes a mistake, in this case, like this instant, wherein a junior optometrist in a early phase of his clinical career unfortunately did a mistake of not doing approaching the high IOP in a way it is expected to, and getting into the shell of guilt, shame, anger, fear, and anxiety. So the person, no doubt, failed their patient, and therefore, what is the impact it carries to that individual because the person carried, the failed in serving the patient, and he, how much ever sorry will not going to work. The sorry is only to transforming the guilt or feel sorry towards your patient, feel sorry towards a senior. The amount of guilt get into you is tremendous, and that's why we call it the second victim. The second victim is very, very, very challenging, which each one of us would have come across. But in our system, whether we do have a system of reassurance and support, guidance on what to do after an error. Is there any guideline protocol exists? There are guidelines to find out the scapegoat. There are guidelines to say you made a mistake and therefore you have to. There will be punishment. Is there any guideline to help them out of that thing? This is something which I feel very, very important in a system when a group of people working together. We have to have a mechanism in the system of clinical care. If we do miss, think about that same person doing an less impactful patient care, next patient care, or in the following days. If maybe depending upon the ability for coping mechanism, the person can come out, but the impact will continue to be there. I'm not going into the finer detail of its consequence, but this is a trigger one, trigger two for each one of us to think through. It is important for us to develop a mechanism within ourselves or at least to others when they are getting into the second victim, a mechanism to give the reassurance and support and help them out so that not only the person benefit but also the next patient whom the person is going to see. The third aspect, again dwelling among ourselves, this is a very interesting case. I know quite a number of instances of this kind. That means among these three, the prevalence of the third one is very, very high. And I think we have to do something about it by proper approach. This is an optometrist wife evaluated a 55-year-old female diagnosed poor vision due to cataract. And it is natural for all of us, so casually we'll tell that I have to refer to you to surgeon for surgery without even thinking what will happen. In this case, exactly things can happen. The need for surgery was expressed with a big word surgery got into their mind, and she felt very, very upset and cannot accept and started crying. And you know what happened? The feedback came from the attender saying that optometrist was rude, hurt the sentiment of the patient, and because of that patient went to depression. All he could have done is told these details to the attender instead of the patient directly. All it means is they are not sensitive to the feeling of the individual. Dear friends, this is another area which I feel there are n number of stories. To that story of a patient, no attender believed the death of her aunt is only because the diagnosis was 10 on phase, but not only the diagnosis, but the consequence of the diagnosis, glaucoma will lead to blindness, had made her aunt meet with a heart attack because of the stress associated and died in 2 days. So that is the kind of sensitivity with which we are playing today. Not all of you, many of you, we don't realize that medical jargons, the wordings which we use casually among ourselves, will be so costly to that individual. Dear friends, this is something which I want to reiterate. Be careful when you reveal. It might not be a normal news, but it might go with a stronger bad news for the person. There is an art of sharing this one, art of dealing with that. We have to equip ourselves to be sensitive to the feelings of our patient if we want to be successful. Please understand there are adequate evidences today, the emotional trauma of diagnosis for the patient and family, it never be taught. If the person is in early phase of diagnosis, first time hearing, at least 3 to 4 time hearing, at least it takes 5 to 6 times before they become, convinced and accepting to that stage. But they will, until they go for shopping, bargaining for different sources, they are still in the state of equivalent to first time hearing diagnosis. These are the feelings of different patients, that how when they've been told first time that they have AMD, when they've been told when they have retinal dystrophy, retinopathy, glaucoma, Leber's, no hereditary optic neuropathy, all these things. Think about it. This is something which is very, very emotional in nature, which is triggered by you and me when we are not sensitive enough to share that information. That is the three components of how we have to implement ourselves in handling our own emotions and our own being sensitive towards the patient. The next three things which I want to bring to each one of you is how psychiatric manifestations can be seen in various eye conditions. Dear friends, this can be read in two clean ways. One, vision loss or vision impairment and fear of future vision loss, and the chronic nature of various eye condition. This broadly two aspects of it, or 3 points, need to be associated with many of the psychiatric manifestation. I'm not telling psychiatric condition, but manifestation in these people. That means people with visual impairment and ocular morbidities, we can see there is good number of evidences on the association. Probably it might be a trigger. There are studies with increasing degree of myopia, because today we are talking more on myopia in every forum. With increasing degree of myopia, there is increasing nature of mood disorders. And there are two great main things which I already told. Anxiety and depression are the two key things that we have to work again and again. Our understanding should grow more. And think about RP patient. There are good high prevalence about associated things, high prevalence of obsessive compulsive disorders, schizophrenia, antisocial personality. No, many other things have been well associated with RP, and there are good number of work. Now, this is one of the simple aspects that we have to keep in mind whenever we come across these patients. I'm not talking whether we have the ability to pick these conditions. If possible, we can also try to do integrate this one by doing a simple screening strategies. Otherwise, at least we can try to sense them. There is an opportunity for them to get appointment with some of these psychologists for enhancement, especially if they give the trigger of some of these symptoms. This is something which I want to share with you. One of the PhD students from, her name is at present Dr. Nayan Gupta, many of you might know. She did a wonderful work on, unfortunately, it's not got published. I had an opportunity suggesting this topic when she was looking for various topic on myopia. I said, this is the topic which we can look. Literatures have spoken about anxiety and depression among people with myopia, and they have demonstrated after giving correction there was some benefit in terms of enhancing the anxiety and depression. But the evidence is not adequate that despite that, if there are group of people, despite the intervention optometrically, if there are some group of people, if so, whether those people might require some of the counselors intervention. And this study has demonstrated few things. The one thing which clearly it says depression and anxiety among this group is high, and it is high with degree of myopia. And the last aspect is sense of coherence is nothing but the coping ability of the individual is also very poor among all these groups. This is a college, there is a comparative arm. They were looking into non-myopic thing, and they found among the myopia, irrespective of the correction, irrespective of the state of the background with which they are coming. This is the challenge they do have. It is an Indian approach. And when they did the depression, when they did the intervention, it was irrespective of degree of thing, there was a proper impact. The intervention was not given by the optometrist, its intervention was given by optometrist and psychological intervention given by the respective expert and team together. The impact was phenomenal, not only expressed by the data, but the expression of the students. Dear friends, this is one other area, yet another area for optometrists when we are talking more about myopia. Is it possible for us to implement this aspect into right from the state of when we diagnose the condition to them and the family member, and also enhance their ability to cope with the different situation and try to help this thing. Maybe around 20-25% of them might have these kind of challenges, but we should not miss out their success in their life or delay their success in life by not doing this intervention. So I want to reiterate, chime in again, glaucoma, AMD, cataract I will keeping away, and DR, all these things, if you look at the prevalence of depression and anxiety is quite high. This is the cause for concern. If you look at this forest plot, it is also demonstrating the odds ratio. It's a pooled odds ratio for the for the condition of that, for the various uh, chronic eye condition as well as mental disorders. It has clearly demonstrated in case of diabetic retinopathy there wherein this no depression to be the higher side, and glaucoma. I'm just running fast, 1 minute. So glaucoma, depression, anxiety, and schizophrenia. Unfortunately, the schizophrenia, the study was only two studies were there, but at least depression and anxiety, it is well demonstrable, and it is also clearly shown in terms of the progression of glaucoma. Um, if we don't try to do this intervention, as against you do the intervention to help them out of the stress, studies have clearly demonstrated that no, the progression can be controlled to some extent. And most of this thing in terms of personality, they found that there is a negative personality among these people, more so with most of the chronic conditions you can come across. And there are some associated literatures on for bipolar disorders, manic depressive disorder, and schizophrenia and glaucoma. The one thing which is very clear among all these things, AMD, DR, and glaucoma space is huge, both in terms of its association with various mental disorders, as well as in terms of the progression of the condition in these issues. ARMD, it is well documented more of its association with depression than the anxiety. It's understandable with age to people, it is more to do with the depression. And some studies have shown it's associated with manic depressive disorder. Again, maybe we can think as one form of depression per se. And this cataract part, I'm neglecting it. And one yet another area which needs a lot of attention. We again try to involve ourselves in diagnosis. Sometimes we try to involve in some intervention. And this has got a stronger evidence today impacting the quality of life is depression and anxiety to the extent of 50 percentage in terms of its association with mental disorder, dry eye. So dry eyes have been associated with sleep disorders, associated with anxiety, depression, schizophrenia, post-traumatic stress disorders, mood swing, manic depressive disorder, many of these things. To put into perspective, we know that screening, probably you can think to, if vision impairment, fear of vision loss, and morbidity, ocular morbidity, or the one which is more interacting with the mental disorders. And if glaucoma plays a huge role, dry eye plays a huge role in terms of its association, do we think that is it possible for us to play a role of screening for anxiety, depression, before and after intervention in these cases and see that whether we have benefited the patient by our intervention, and if not, why not we refer. This is one of the thoughts that I was thinking on. And second one, whether screening for vision related health quality of life before and after intervention, in addition to that, to looking into the patient related outcome measures like quality of life issue, can be integrated into everything, which many of the clinical trials they are trying to do nowadays. But is it possible for us on this pretext we can try to bring into our practice? At least today we do have a stronger evidence, as I told you again, and all these things. And therefore, is it possible for us to either have an association, collaboration with counselors, psychologists, psychiatric experts, and see that teaming together will add a meaningful value to in our practice to our patient. Some of the tips for people who might be thinking how to handle this. Um, as again told, we are not expert in it. We have to agree on that one. And then, but you can try to pick some of the tips on who is anxious and who is so depressed. The best example I could quote is, think about your early years when you have been asked to come onto the stage and give a talk. That butterfly, that is anxiety. Early years, you think about your results coming tomorrow, or that butterfly which you carry is your anxiety. So that kind of anxiety is what you can always gauge sometime by way the patients talk and pay the patient express and observe. A depression you can always appreciate, but again I'm telling with condition apply, we are not expert. But if you have a doubt, maybe that is where I was thinking a screening tool of questionnaire will be a more meaningful. Irrespective of the thing, one thing which I feel great learning for all of us is the understanding the patient as they are. That is the positive psychology. We should have the empathy more and compassion towards our own people, for which is it possible for us to have a more of listening ability and ensure that persistent care for these people, and understand that people want to hear from others who can relate it. So these are something which we can always handle it as a take home message for each one of us to carry forward to bring in some change into our clinics. Please understand these kind of improvement, this kind of initiative by trying to collaborate or trying to bring in, again being demonstrated in the literature, how it is beneficial from the mouth of patient with glaucoma, patient with retinitis pigmentosa. Despite hearing that our counselors in many of the places is only spend time on talking about what are the types of cataract surgery available and what cost much and what is IOL, like what we talk in terms of progressive lenses and other in terms of cost. Have we really giving that experience of giving them the proper confidence to enhance their not only their vision but also in terms of quality of life by giving a good emotional support? All I'm going to say is there is an evidence today. Only thing the implementation is lacking. Okay, now we do understand all these things, and if we try to give to the eye care professional in terms of their input about different kinds of patients, this is a study which was clearly showing if we give the emotional status, the knowledge of emotional status of each of your patient, whether as a clinician, in this case ophthalmologist, whether they utilize it to serve their patient, unfortunately, this study have demonstrated they don't utilize adequ- adequately, or not all of them utilize it. The reason being, most of them don't know or adequate training in how to handle the presence of anxiety and depression and how that will have an impact on the care. The simple logic is the compliance part can be enhanced by handling this anxiety and depression in these people. Dear friends, it is not only for ophthalmologists to the study, it is also learning for us. What is that I'm going to do if I'm going to implement a tool for picking up anxiety and depression? What I'm going to do with should be really thought through by senior members in clinics and try to see whether we can adapt some meaningful strategy that will benefit the patient. So take home message, we know the impact of illness on emotional stability of the individual if you adapt. We know how to screen for the emotional stability of the individual, provided we implement the screening strategy. But are we equipped to interpret and utilize the information in our eye care services? For optometrists, we can also think in terms of procedures. Do we adopt forced choice psychophysical techniques in checking visual acuity for these people with various emotional challenges? This is the method that we have to follow. Do we prefer to do JCC and try to elongate the process if you are not confident whether that can be understood by the thing, or we do have an alternative refining techniques? Do we need to have a huge jump in correction to go in, or in go in steps of 0.25 for going and fogging? We don't know. All these things might have, will have, we don't know, an impact on how to deal with the especially people with no emotional challenges. So the next aspect is on the psychiatric impact on eye condition. We saw the in ocular condition and psychiatric thing. Now we can look into what are the psychiatric conditions will have will have an impact on our eye condition. Stress, I already told, increase IOP in angle closure glaucoma and normal tension glaucoma. Many of you we heard about people know have increased blood pressure when they see the white coat, or sometimes they will have a high blood pressure when they see someone who is not making them comfortable, put them into stress. So too, it has been demonstrated increase IOP in angle closure. But how many of the other people got stressed out when they came to you and we found out that the pressure is very high? We don't know. Whether it is associated as possible trigger for uh, CSR, is most of the time we try to see our photopsia in RP. Again, there are quite evidence, personality, A and CSR and so things. And photopsia in some of the patients with RP is also been associated with stress. So is it possible, or shouldn't stress be a crucial consideration in the treatment protocol for all closed angle glaucoma patient and CSR? We don't know. Is there any evidence that we can try to bring in, or at least we try to start looking into it? The next aspect is quality of life and mental health status. Status of glaucoma patient is well linked in the literature. Does this mean whether we need to consider, evaluate the quality of life and screen for mental status of all our diagnosed glaucoma patients in the clinic? I've already shown a stronger association with various psychiatric condition in glaucoma. We don't know whether one will have an impact on other in terms of progression. So this is something which we need to really look and see whether we can implement it. As I told you, type A personality and CSR, acute and chronic depression associated with the dry eye condition. There are a few mechanisms are floating down nowadays. Anxiety with demonstrable loss of retinal fiber layer thickness in glaucoma. Anxiety and depression and blepharitis and dry eye has also been well documented. Schizophrenia, there are a good thing, but unfortunately, in my small group of thing, I couldn't find any of these things. But I also accept that my experience of really looking into various visual processing aspect is not too great. Probably we are required to really relook into this. The studies have shown early visual processing, especially in terms of contrast sensitivity, motion perception, brightness, and eye movement control. Only thing I realized in two aspects in my small group, that there are few people had a very vague kind of eye movements, especially when I asked them to see. It looks like anxiety driven one, or some people staring stone, keeping stone face and try to respond, or sometimes they don't. That is the kind of things. In terms of eye movement, there are few evidence that I could get with small, but literatures have talked more about it. And literature is also talking in terms of retinal venules widening. And of course, I've seen some of them having the tortuous venules, but That is something which we have to really see as an indicator, or it can act as a biomarker for schizophrenia. I don't know. Retinal nerve fiber layer thinning, and abnormal ERG. Both, at least in personal experience, I don't have any of those indications. And its association with maculopathies, retinopathies, cataract, poor acuity, and strabismus. Pure acuity is with a lot of time it has been associated, and many of them I've seen with alternative squint. I don't know is it associated factor or there is some relationship per se. Bipolar disorder is another gamut demonstrated with proportionate with the severity, the retinal nerve fiber layer thickness thinning out, this and deficiency dot motion trajectory discrimination. Maybe one of these things will act as our biomarker for us to refer. Maybe in addition to, we have to find out some of the psychiatrists how we can implement these kind of thing into our practice. The next dimension, which I thought probably is the last one, is ophthalmic medicine's impact on the mental health, as well as I will talk in terms of psychotropic medicines and things. At least some of these documented evidences like beta blockers, anticholinergic cycloplegics, corticosteroids, and carbonic anhydrates have been some related to some of these emotional triggers. But the question is, it is once it's been removed, it will go off. But the question is, if the person is already prone for it, whether we need to use it or not, I don't know if any such literature existing. Are we going to trigger it, aggravate it more? So in that case, what is the protocol that we have to adapt? Maybe some of the ophthalmologists can try to throw some light, but literature doesn't carry those kind of information for us to see how these information can be processed into our clinical practice. And next, this is on some of the psychotropic medicines, and wherein at least these medicines have been found to have an impact on these 5 dimensions. One, especially when you feel that some of the patients coming to your clinic is a psychiatric patients, you find out what are the common medications they use. And if you can try to use the checklist and see any of those things and look for these kind of no signs in the eye, like impairment of eye movements, angle closure glaucoma, eyelid and keratoconjunctival disorders, especially more of pigmentations in in the lens, and eyelids, and as well as some cases in the endothelium. So retinopathy, all these things you can, any of the retinopathy, we can always look into this association in thing. Since I don't have personal experience of these things in this small group of people, except for increased intraocular pressure, probably induced by no the medication. Unfortunately, that patient was using SSRI. Topiramate was not in the game there, and immediately the patient got referred. Unfortunately, the patient, though being referred, the family members are not willing to take them. It almost took almost 6 days. A positive thing is the disc was normal at the time. Patient never had any medication, probably because of psychiatric medicine. So unlike other patients where they might have some kind of symptoms, these patients didn't have any symptom. At least 4 people with high intraocular pressure in a small group of 40 odd people. But it is important for us to look into. One thing is very important because angle closure consequences so drastic. So it is very important that we have to give a lot of attention for people who are using psychiatric medicine, any of these aspects in our clinical thing. There is a huge list of things. I'm not going to get into it. Just I want to run through some of it. There are anxiety related medication, epilepsy, because most of these people, especially people with congenital thing, you can see epilepsy is very, very common, and they will add on to those medication, and its adverse effects can be noticed. And schizophrenia specific, there are good number of medication that is also have good association. And mood and behavior, mania, lithium, antidepressant. Again, we see many times we write antidepressant medication. At least we can try to look into some of these mechanisms. And this is one case report wherein they documented endothelial and corneal stromal layers, which is being pigmented with stellate type of cataract. in patient who is using chlorpromazine um, uh, for his psychiatric problem. And this is another case for topiramate, which I told, wherein it's clearly demonstrated with angle closure, which got relieved on once it has been topiramate been relieved in this removed from this young 7-year-old. It is also seen in some of the case studies with elder patients. So that's the key area that I would like to share with you. If Gopi allows, I can share some of my basic experience on with this group.
Yes, sir. Yeah, please.
Okay, so this is as I told, I'm sharing as one home. Purposefully, I'm not trying to dig more information on intellectual disabled people. Um, this is around 54 um, patients. Interesting aspect of it is many of them had their last comprehensive examination almost 3 to 5 years. Kindly underline this. It is a vulnerable group. And if the dialogue between them and me is this, sir, whether you have a glass, I have a glass. When did you had your last examination recently? Where is your glass? It is at my home. When how long you are in this center? I'm here for 5 to 6 years. You can understand the no meaning of this. Meaning is they had class, but they didn't bring the glass. The glass is at home for the 5 to 6 years. Despite the need, they never had the glass, never had an eye examination. This is a very important area which I felt that itself explained a vulnerable group per se. That means we have to add, in addition to geriatric population, women, rural, people with differently abled, a group of people who definitely needs the care. Interesting aspect. Many places we feel the felt need part of it. The felt need among these people, as much I garner and as I understood, because when we evaluated, we also had a psychologist aside next to us, and there was one strong man's be there to help us out if any challenges arises. So the felt need was good vision is only among 25% of this group. That is something which we have to keep in mind. And despite that, we prescribed almost 50% of them glasses, and 13 of them we referred. The spectacle compliance, once again, women win than men. Very interesting story I had when I went back for compliance part of it. Of course, the referral compliance was quite a challenge because it is not uh, the in charge at the center can decide. It has to be decided by the family members, and family members are sitting across. So that is the challenge. Hope we will get through it. But uh, with Ben, actually, very interesting story. When we went back, and I told Mr. Mahalingam, who accompanied me for this session, I told, can you just go and find out with this basic question in hand, whether those people are using it or not, and when if they're saying they're using it, you try to see where they kept the lenses so that we know. Out of 26 people, I don't know how many of them are male. We found at least four of them came with very interesting story. All of them said it got lost, and we don't know what happened. It got lost, and they also pointed towards one person. And just that is another interesting thing. They don't say it is broken. They don't say, uh, I forgot to wear the glasses. They tell the truth that it got lost. Now, the question is whether it got lost or they kept somewhere, they forgot, or they kept purposefully somewhere that so that they can give this information. We don't know all these things. But after counter checking with the psychologist said, no, no, there is one notorious personality, and I could recollect that person. He kept on asking for glasses on those days we went, and since we didn't give him the glass, probably according to their theory that he would have collected all these four glasses which were lying probably outside and would have kept somewhere and forgotten the glass where he kept. So there is a simple story which I want to share with you. So in this group, predominantly people were schizophrenia, It was diagnosed by psychiatrists, and other group of people were there. That means almost 65% of the people whom we evaluated are schizophrenic. And if you can look at the age, predominantly the age is between 40 to 60, almost 33 of them of that age group. And if you look into closely, predominantly male were there than the female. Maybe reasons can be a female, probably a family would have not felt comfy to send them to the center. We don't know. The ocular condition, almost predominantly of the people felt they don't have any symptom. Only few people told about near vision difficulty or distant visual difficulty. Only 1% told foreign body sensation. Very interesting thing. Again, it is a surprise for me because I expect them to give a lot of information, and they were quite normal. Otherwise, they said many of them felt that they're happy. They could see what they want to do. Some of them are doing their work. Like one person was doing medical transcription work from within the space, and the other person was doing work from home at this place. These are all surprise for me. One person is IT personnel, another is a teacher, another is this medical transcriptor, another was in pharmaceutical company. There was a dropout from medicine. So there are combination of more learned people in this area. Otherwise, it indicates the need for vision and reading based on their routine in their life. It's very closer to the vision dimension than anything else. So vision care among these people to see better is very important and pertinent, apart from for various reasons when we connect with the medications and other stuff. So at least I could see some of them, good number of people with cupping, maybe referred. Still, we are following up. This is something which literature talks more of mydriasis associated with many of these things, but I saw pinpointed pupil. I don't know how it's thing. I also mentioned this to those group, and we have to find out what need to be done in these things. So that all something odd. In terms of their systemic disease, again, hypertension and diabetes occupied a huge space like any other common group, except for one person. I never seen anyone with obesity in this group, at least by appearance, not by diagnosis. Only I saw one person, and that's again a surprise for me. And these are the medicines they use for schizophrenia patient. I'm not telling, because when you give schizophrenic medicine, it's not only for, they also associate symptoms and signs they try to give. So for example, the medication for sleeping they give, no, those kind of medication also integrate people for seizures they give. So all these things are combination. So these are the medication, just to share with you. For example, risperidone is something they say it is very commonly used for no, for this condition, schizophrenia. And medicines for psychosis patient, again, it's all, there are a lot of overlapping between this as well as the schizophrenia. Dementia is almost correlating, because dementia most of the time people with 70 and above. Very interesting. There is a one patient of dementia came clearly as if she doesn't have any dementia. She said, I am not very keen for any eye examination. I can see the chart and beyond the chart also. I don't want any eye examination. And I requested, can I at least document what you see beyond the chart? She agreed. I documented the vision. They said, now you documented, I don't want any other examination. So they are very clear. This is the patient with dementia I had. Very interesting one. And we have seen some of these OCD patients with all these medication. OCD patient try to correct where you keep your lenses, whether back into the space or not. They are very particular how you are writing. They make a lot of observation. Beware of it. This is something very interesting. Many times I've seen in our clinics, we try to throw the lenses here and there than in its original place. And this OCD patients are the one who should come and try to help you. That is one aspect of it. There are many other aspects. Just I thought it is correlating with our needs as well. So OCD is another group of people with this medication, and hypomania is people between mania and depression. a very interesting thing. Most of the time, maybe sometime we are classified as a bipolar group, but in this case, it's one patient alone I saw has been diagnosed with hypomania, not as bipolar disorder. And the take home message for overall my thing is, please understand this is one yet another vulnerable group. We are having by 2020 data almost 119.7 crore. Maybe there are many would have not been diagnosed at all. And this is a vulnerable group where it required screening, required care at their doorstep. And second, the emotional status of the practitioners, optometrists, please don't neglect all the messages. Don't carry your personal things to your office and vice versa. Please give importance to the negative emotion, which might be a consequential in nature. See a system to help so that your patient benefit, the next patient will benefit, and be sensitive towards your patient, especially when you share their talk with them, express their diagnosis, and so on. And ophthalmic condition, especially vision impairment and chronic condition, and the fear of vision loss, and mental health, especially anxiety and depression, a big chunk, and schizophrenia and bipolar disorder. And of course, I told intellectual disability, autistic spectrums, and ADHD. There is a pediatric optometrist group might be interested to work on and see how much we could contribute. Ophthalmic medicine's impact on mental status. Um, Please don't neglect into looking into whenever you follow this patient with these medicines. Psychiatric disorders impact on eye conditions, stress especially, and its influence on the glaucoma. Try to highlight, put in a bucket that glaucoma needs a lot of attention. And psychiatric drugs, psychotropic should be psychotropic medicines. Impact on eye condition should not be neglected. These are the messages which I thought I want to give to each one of you. I don't know whether I delivered it, but I still strongly feel this is one area we need to really see as an optometrist. We can contribute. Each one of you can look into it and try to make it possible. We are going to help yet another vulnerable group, deserving group who needs more attention than what we are giving today. And thank you very much for patient listening. And I'm also happy to take some of the questions.
Thank you so much, sir, for giving this insightful talk. As always, it's inspiring, and I just thought I will summarize quickly what you were mentioning. And it was very interesting to see the examples, like though it was not a real examples of optoms, the be personal or professional way of having psychological aspects, and how important is to express things in front of patient, and role of the questionnaires, be it a simple questionnaire used in your clinic to pick up very basic, though we are not experts in psychology, but importance of having a questionnaire, and also putting out a lot of research questions for the youngsters. We have one question in the chat box by Shia Shetty. I think, is poor visual acuity in seesophilia patient a result of acute visual impairment, or could it be an underestimation of visual acuity influenced by psychological or mood related factors? So they want to know what could be the reason for having a visual impairment in schizophrenia patients.
Um, no, it's not that way actually. See, when in terms of the procedural challenges, uh, none of the schizophrenic patients, if they are under medication, you're going to deal them like any other so-called normal patient. Okay, there is no challenge. Okay, of course, if they are not taking medication, as I told, narrated the first incident, they might take us totally to another direction. That is because of our ignorance more than their intention. The second aspect of your question is vision impairment among schizophrenia. Is it commonly seen? And if so, is there any specific reason for it? Um, Again, there is no evidence on it. Vision impairment among these people, if triggered by any of the medication, has been demonstrated to leading to, for example, glaucoma. For example, you neglect the glaucoma. For example, you neglect the cataract for reasons. They say our first focus is only to take care of their cataract, so that we can take care of their health, mental health. So don't waste time. Or the family members will decide that no, no, we take up the thing. Why? What she is going to do, or he going to do the no with good vision. All these things put them into things. So many of these things are would have been an avoidable visual impairment, which is more of triggered by the societal decision making onto them, or being neglected to being taken care is what my take. But literatures have shown that among this group, vision impairment is common. But the reasons, if you look, it is not because of any specific pathology too. I don't know whether I've answered, but it's a good question. Thank
Yes, sir. I don't see any questions. Saravanan, do you have any questions to ask, sir? Or we can close the session?
One question is there when we deal the psychological aspects, have you just to in your experience encountered any difference in acceptance as an optometrist saying versus the ophthalmologist? Is there anything like that?
No, no,
The
no.
who say,
I don't know. You need not to bring in any of the psychiatric problem per se. The knowledge about each of the profession we decide, that will decide the credibility of an or no of the profession. Now, for example, if you go to person, bone doctor, ortho, or you're going to a physiotherapist, and now there are few people will realize that probably I might go as a primary care for physiotherapy, and then the physiotherapist advises no, it required surgical intervention and other care, going to ortho, or vice versa, ortho been seen and he advises for the need for exercise therapy, I go to physiotherapist, is purely decided by what amount of knowledge an individual has in terms of the job profile of an individual. So that will decide most of the time. So I find the responsibility, it is not with the patient per se. What kind of information awareness we try to bring in when we encounter a patient, to tell about our profession, introduce us, like one of the forums, Premnandini was talking, telling that how many of us actually introduce themselves as optometrists to their patient. So these are the aspect that will bring in the change. It has brought a lot of changes today, but I don't account it for their uh, their psychiatric or psychological issues. It's accounted it for their knowledge and ignorance.
Thank you so much, sir. Think with due to its time, thank you so much for giving your all your insights at our Acchutha INSPIRE series. If you want to listen to the for the participants, if you want to listen to the talk again, we will upload it soon in the YouTube, and we will see you in another Acchutha INSPIRE series. Thank you so much, sir.
Thank you all.